and moving towards the oral version of GLP medications, and they are showing some, just injections, Govi pill and Fundayo. Um, and like because a lot of people are asking that question, so I just want to get your take on that.
So we kind of touched on, the efficacy and the how you take it aspect of
Hmm.
it.
Hmm.
So oral Wegovy is just straight semaglutide. It's the same thing
Hmm.
you inject. They've kind of encapsulated the pill a little bit differently than just straight oral Wegovy or oral pills of semaglutide. But does make it a little better to absorb. And again, they added the restrictions, empty stomach, nothing to eat or drink for a while to get it to absorb a little bit better. So they've gotten it closer to the injection version, but not quite all the way there. But it is just straight semaglutide. Fundayo is more of a engineered product, kind of like you were describing. Trying to engineer a product that can be taken by mouth, that doesn't have quite as much issues absorbing.
Hmm.
So it is more of an engineered product. It doesn't match any of the other injection type products that we have, but it does act similarly. It's very different structurally. So it does absorb easier in the stomach, but again, it's less effective overall if you look at the studies. So you're getting trading off convenience, taking it anytime you want,
Hmm.
versus effect.
Hmm. Hmm. Yeah, 100%. I think they add some extra coating to it for
Mhm.
for it to be not like interacting with your stomach as acidity and then like still have its effects. But then there's also the trade-off. Okay, so one of the other questions that people have been asking, and we sort of addressed that, but just based on your personal opinion, how much weight do you think our patients tend to normally lose? And based on your experience, working in this industry with the GLP-1 pills, like how much of a result have you seen with patients taking these
Mhm.
pills?
So again, it depends on the pills. So
Hmm.
oral Wegovy with all the restrictions, what they quote is about 15%, between 13 and 15%. Whereas the shots are more like 15 to 18%.
Hmm.
With Tirzepatide, you're looking closer to 20%. If you're looking at effect through there, with the Fundayo, like I said, you're looking more teens, somewhere in that ballpark. A 10 to 15%, somewhere in that ballpark. And generally, that's sort of what we see with like ODTs. Compounded versions, similarly in that sort of ballpark. But if you look at things like we were using before, like Contrave, metformin, things like that, they're somewhere between 5, 8, maybe 10% at best. So they're better than anything that we had before. Not as good as the shot. So you're sort of in that, in that ballpark. But with oral, unless you're looking at oral Wegovy, you're looking at 10 to 15% at the high end.
Hmm. Hmm. 100%. Um, and okay. And do you think like there's a certain demographic that is a better candidate for oral versus injection, or it's just a preference of the patient?
Mostly preference for the patient, but again, like that, if you're not looking to lose a lot of weight, you're looking more to maintain. You don't want to mess with shots. That's great. If you travel a ton and just shots just aren't going to do it,
Right.
aren't going to work, then the pills are sort of your best option. But I generally look at someone who doesn't have much to lose, doesn't want to lose much, or what just wants to maintain. That's a perfect, generally usually cheaper, more convenient type option than lugging the shots around week to week.
And one of the other things that I've noticed with the pills is that they have better shelf time per se,
Mhm.
so they're not going to be expiring
Right.
as much as the injection forms. But ultimately, as you mentioned, it boils down to the patient's preference at the end of the day of
Right.
whether or not they want to take it as a pill or they want to take it as an injection, with the trade-offs that you've talked about. Perfect. So one of the other questions that we have is, would you recommend a patient who's currently taking the injection to be switched on to the pill version if they want to do that, or if they say traveling for about 2 months, or what have you, for a variety of
Right.
reasons, right? Or maybe like discomfort. Would you ever recommend that, or like you would not? Because there's obviously that trade-off, right? Like if somebody's on
Mhm.
tirzepatide injections, they're going to be seeing a far more interesting amount of weight loss compared to the pill version. So, would you recommend that, like somebody switching off between back and forth from pill to the injection, or from injection to the pill version?
The issue is anytime you trade medications, um, the way all these medications works, whether the pills, shots, whatever, all the different versions, you start at a low dose and kind of slowly work up the steps. So generally, when you switch over, you usually end up losing a little bit and kind of dropping back a little bit just to get your body adjusted to whatever the new medication is, and then working back up. So yes, you can switch at any time. It's not a problem, especially if you hit a level where you feel comfortable, you want to switch to something more convenient, something lower.
Mhm.
But kind of switching back and forth, you end up sort of losing months here and there. So you might be at highest dose of injection semaglutide, switching to the pills. So you have to just take a step back just to be safe. So you kind of lose a month there before you bump to a kind of a higher dose. So jumping back and forth is not great because you're losing time. Kind of taking 2 steps forward, 1 step back, 2 steps forward, 1 step back. But again, if you're looking to switch, that's absolutely fine. You can easily switch, from one to
Mhm.
the other. But usually you wind up stepping back a level, depending on what group you're on. Um,
Yeah.
just real quick, we had a question
Mhm.
Jennifer asked as far as how soon do you increase?
Uh-huh.
So the injections, most companies, and we follow kind of what the brand dosing is, which is every 4 weeks. So 4 weeks with an increase. Pills are the same. So it's 4 weeks or 30 days. It's usually a 1 month supply with increases. And oral Wegovy, Fondayo are the same. They do 30 days, 30 days, 30 days, 30 days. Zepbound does 4 weeks, 4 weeks, 4 weeks, 4 weeks. So it's all pretty standard, pretty set.
And we have another question too. I think Timor. This is asking about because they're going on vacation for about 4 days and in a couple of weeks and won't be able to take any medications with me. What do you suggest I do prior to my trip? Would you recommend them taking their shot if they're taking a shot, or if they're taking a pill, they can obviously take the pill with themselves?
Yeah, take the pill. I take the pill with you, obviously, but this I'm assuming is used with a shot. So you have a couple options. So if it's within a day of your injection, then just take the injection either a day early or a day late. So let's say if your injection day is typically Sunday, you won't come back until Monday. Taking the shot Monday is fine. Usually 24 hours, even 36 hours, kind of either direction is fine. If it's right in the middle of your shot date, generally recommend to split your dose up. So take half a dose before you leave and then half a dose when you come back. So you kind of split that whole week out. What you don't want to do is take your shot on Monday, then take another full shot on Wednesday, and then go on a 4-day trip because that could make yourself sick. So either do the full shot, and then if it's getting close to your shot time, do kind of half a dose and half a dose when you come back instead of doing that full week all at once.
Hmm. Hmm. Well, thank you for that. We have a couple more questions actually on our side, but
Okay.
please, guys, ask your questions. Honestly, these are I think these are really good questions, and these are the questions that sometimes we tend to overlook. Like our patients would have to travel too, right? So, what do you do when you're traveling? And what do you do if you're traveling for 2 weeks? I actually haven't thought about it. Like, how would you recommend a patient go about their, because there's no what we want to avoid is lapse in care. So how do
Right.
we recommend a patient go about taking their medication if they're going on a trip for about 2 weeks instead of like a
Right.
month, or like instead of a week?
Right. So you can't take it with you. So I know we say to refrigerate it, but it does last at room temperature even for a couple of days. So what I'd recommend, if you can, fill a vial, pack it, Kelsey, keep it in your carry-on. Don't check it because it can get too warm, under the plane, depending on what time you're flying, or too warm or too cold. Check it, just stick it on ice or a fridge whenever you get wherever you're going, and then take the shot. Then, if you can't, generally skipping 1 week is not terrible. If you skip 2 whole weeks and you're on kind of week 3, we only recommend decreasing your dose, maybe 50% for the first shot, and then go back up to the full dose the following week. The issue is, these medications have kind of long lag time, and your body adjusts. So, when your body is without it for a while, you sort of lose that tolerance, and then kind of repeating that dose, you can get pretty sick. So, again, try not to skip more than 2 if you can. I said you travel with it. It's really not that big of a problem. If, carry, just fill a syringe, put it in your check bag. Usually it's fine. If you need a letter from us stating that you have a medical purpose for medication, what it is, you can send it to us. We can send it to you. I'm sorry.
That'd be amazing. Yes, and they could take that letter with themselves to the airport, and hopefully
Hmm.
you'll be good to go, and they're not going to give you any hard times.
Yeah.
We had another question actually. Patients on their second week of shots doing 9 milligrams,
Mhm.
and they are asking if they're going to be seeing a more of a side effect going
Mhm.
from 9 to 13, and my question is, how do we mitigate that?
Right. So generally, what I have seen with patients is if you tolerate the early doses are the hardest part. If you tolerate the early doses well, I mean, some people breeze through them and have maybe a tiny little constipation or nausea through, but they really don't have any problems at all. Then they generally have no problems at the higher dose at all. If you struggled at the early doses, the bigger doses kind of just stays the same as far as the struggle. As far as, if you have nausea, with every
Mhm.
jump, you're going to have nausea again, similarly to the jump to 13 as you did with the jump to 9. Um, the nice thing about with the compounded medications versus the brand name is we can adjust the dosing. So, if you're concerned, if you're at 9 milligrams and you're still having some nausea, or you had a lot of nausea and you jump to 9 milligrams, you don't want to jump all the way to 13. Then you can take, 20% off of your dose, cut yourself down to like 11 milligrams, do that first for 1 week, see how you feel, and then go up to 13. So what I tell people is, the dosing recommendations we give you, consider that a maximum, right? You can't go above that, but you can always go below that if you feel more comfortable. So if you're feeling like, I don't want to jump all the way from 9 to 13, then just take, 20, 25% the recommended units. That'll get you down to about 11 milligrams and take that first and work your way up. And same thing, if you take a dose, if you do a jump and you have a lot of side effects, then the following week just decrease it, somewhere between the two doses and take that. So you can always titrate it down however you feel comfortable.
Okay. Now, also for those of you who are joining us just now, stay until the very end, and that's where we're going to be giving the gift card. So just like stick around for a while, and then ask your questions. Okay, perfect. Um, you're welcome. I guess one of the questions that I wanted to ask you, and then we can probably talk about it, is Zofran. I mean, Zofran is something that is being commonly prescribed. It's basically just anti-nausea medication,
Mhm.
or the real name for it, I think, is Odanstron, which has some very minor side effects, but also helps with mitigating the nausea. Do you think that the patients who are feeling like super nauseous after taking the medication, they should take the Zofran, or what are some of the counter indications that you think like somebody shouldn't be taking the Zofran if they have
Sure.
certain conditions?
Sure. So first thing, we'll just go through the nausea sort of
Hmm.
portion, because nausea is fairly common. So there's sort of two parts of that. One is reflux. So you do get a lot of acid. People report, sulfur burps, reflux, things like that. So if it's more related to that, taking an acid daily, even twice a day, I generally recommend. So anything over the counter, Pepcid, Zantac, generic brand, whatever, chew Tums, so even taking one of those daily medications even twice a day, when you first increase the dose, is helpful. Then chewing Tums as you need is also helpful. Anything with ginger in it is great. Ginger tea, ginger hard candies. Those are great, great kind of pregnancy trick for nausea. Another weird trick is alcohol, not drinking alcohol, but rubbing alcohol. Um, Take the alcohol wipes that we use to kind of clean our skin. Actually, sniffing those reduces nausea.
Wow.
When I worked in the emergency room, we used to put them in the mask. People that were really nauseous, we put a couple in the mask and have them breathe that in. It actually is really potent for reducing nausea. So that does help in a pinch if you have anything around you. But obviously, if you're having severe nausea and other stuff isn't working or you're vomiting, we can easily send something either with you with your prescription or to your pharmacy. Um, we generally offer the under the tongue dissolving because obviously if you're vomiting, swallowing a whole pill is hard. Um, Generally, we use the generic Zofran is very well tolerated. Our general prescription is 4 milligrams. For cancer patients, they go as high as 64, so 16 of those tablets at once. So it's a fairly wide range of treatment. Really, the one main issue with it is it can change the electrical system of the heart, so it can cause what we call a
Hmm.
prolonged QT.
Hmm.
So if you have an underlying history of prolonged QT syndrome, it's not advised to take it. Or if you take actually large doses of medication also cause prolonged QT. So particularly like antidepressants. So you're taking very large doses of things like Zoloft, Paxil, things like that. That can prolong your QT. That little bit extra that Zofran causes can cause an issue. For most people, it's not noticeable. But if you already are like in the danger zone, that little bit extra increase can cause problems. That's really the only thing we look
But
for as far as
if somebody's
Zofran.
on an SSRI, and SSRI for you guys, it's a serotonin reuptake inhibitors. So essentially, it's just kind of like have more. You're going to have more serotonin in
Yeah,
your system,
that's your
and it's
Zoloft,
usually
your
prescribed.
Paxil, your typical
Right.
antidepressants,
So there's not much of a
antihistamines.
counterindication for the people who are already on SSRIs
Right.
to be taking like serotonin syndrome. They're not going to get the serotonin as syndrome. I guess the typical flushing and stuff like that. It's not like a necessarily like a counterindication if you're already on those medications, or is it?
It's not. I said if you're a higher dose, generally we wouldn't recommend the Zofran. Just generally recommend having your QT measured, which is done through an EKG, which also we can't do
Uh,
in this matter. So if you're on a very high dose, usually your doctor will kind of advise you, hey, watch out for certain things. And so we avoid that. But if you're on a regular standard dose, you've been on it for a while, generally it's not an issue. Generally, if you have been diagnosed with that before, people usually know and have been told.
one of the questions that we had. So what does FDA approved actually mean when it comes down to, say, medications or weight loss medications?
Sure. So, FDA approval is extremely expensive. And that's the real kind of gate. So you have to have a very large study showing that whatever you're trying to get approval for works for whatever you're saying it works for. So there has to be, for a company to do that, there has to be a financial benefit for them to want to go through all those hoops to do it. So obviously weight loss is, as you can see, a big popular drug, makes them lots of money. So it was worth it for them to go through and do it. In fact, they did it twice. They did it first for diabetes. Like Mounjaro is Tirzepatide, FDA approved for diabetes. During the study, they found that they caused patients to lose weight. So they had to go back and do it again. The exact same drug, exact same dose, exact same everything, renamed it Zepbound, and now it's FDA approved for weight loss. It costs them millions and millions of dollars to go through that approval to get the stamp to say, yes, this actually works for weight loss. But again, uh, using, for example, a compounded medication maybe has something a little different or slightly different dosing is not technically FDA approved. So no one's gone back through and said, 15 milligrams is effective, is 18 milligrams effective, is 20 milligrams effective. No one's gone back and done that yet. We saw it with Wegovy. Wegovy stopped at 2.4 milligrams, and then they went back and actually, redid a whole nother study at 7.2 milligrams, so 3 times that amount, to get Wegovy HD approved. But no one that was not FDA approved until they went through and did the study and did it. So FDA approval really just means that you filed all the paperwork, you did the study that shows that it works. But that's really not possible for like every single dose, every single mix, every single compound.
And okay, so and one of the other questions that our patients had. Um, okay, because I'm trying to keep track with all the questions that we have so that we're
Sure.
not losing any of the questions. Um, So the patient is saying that they've been on the medication for a while and now they're starting to see a plateau. I do
Yeah.
know that there's a sigmoid curve in terms of how much weight you're going to be losing. Obviously, not going to be much that in the
Mhm.
first month, and then it's going to be significantly higher from that. So can you possibly like talk about it a little bit too, so that we can address our patient's question too?
Right. So, I mean, I think overall, I look at it, we had discussed it last time, as a scale, right? So, inside our brains, inside our bodies, there's a push pull. There's the side that wants us to gain weight, maintain weight, and part of us that wants us to lose weight. So, kind of the good and evil sides. Um, you know, People that struggle with obesity, generally, it's kind of tipped towards the evil side, right? The side that wants you to gain weight is beating the side that wants you to lose weight. And so we're constantly kind of gaining weight as we get older. These medications kind of push the scale down on the lose weight side. So early on, so the scale will move, but maybe not enough that you lose weight until you get to a point where it does tip and you start to lose weight. So that's generally, like you talked about, the curve where a lot of people don't lose weight early on, then start to lose weight once you kind of hit that level where it sort of tips. So that's something I tell people to look out for. You're not going to likely will not lose weight very much early on, but eventually you'll kind of reach that point where the scale tips enough in favor of losing weight and you start to lose weight. The other issue is that fat actually, having fat actually actually pushes on the lose weight side. So having fat, the fat cells themselves actually pushes you to lose weight. So as you lose the weight, you lose that drive to lose more weight, right?
Hmm.
So if you think, evolutionary, if you are losing weight, your body's going to think, I'm in trouble. I need to stock up food. It's going to start kicking in the hunger response. So as you lose weight, that scale actually pushes itself back. So it's not uncommon, for example, if you're on a certain dose, it tips like this, you start to lose weight. Now it starts slowly kind of works its way back until you hit an equilibrium and then you plateau. Um, so then you need to sort of find ways to push again on that lose weight side of the scale, whether it's an increased dose, sometimes adding additional, another medication, things that, again, push on that scale, things that we can control. Sleep is a big one. Studies have shown over and over again that, same person, same eating habits. If you sleep less than 6 hours or more than 6 hours, they tend to be 10 to 15% heavier if you sleep less than 6 hours. So sleep is a big one. Stress is a big one. There's all sorts of things that sort of tip that scale too. So it's not uncommon to kind of reach a plateau at some point. Eventually, your body just sort of reaches that level.
And I think Jennifer had a question too, about, I think there's something about the similar subject. So she's asking, she's on semaglutide right now.
Mhm.
She's on week 1 to 4, she was taking 12 units, and then on week 5 to 8,
Mhm.
24 units, and the 36 for weeks
Yeah.
9 to 12. Typical, I guess. Sequence of
Mhm.
things and units. But it says the new vial says weeks 1 to 11 should be 36 units. So no increase. Am I not really having symptoms? I am not really having symptoms or weight loss. And the patient started on May 26. I guess the patient is asking whether or not she should be increasing her dosage or not. And she says that she's not
Yeah.
necessarily having any sort of symptoms.
Yeah, she should be. Now, we had an issue with our kind of vials where, we were trying to do 3 full months, but the vials weren't covering a full 3 months. They're covering 2.5. So you're kind of getting a second shipment to cover that rest of that third month, which was the 9 milligram. So just message us, let us know. We'll sort out what you're on and get you up onto the right dose. But ideally, unless you're having side effects, we should be increasing kind of every 4 weeks.
Thank you. And Girly Girl 83 is asking if Miralax is a safe thing to take while taking the shots. I'm not too sure what Miralax is, but
Yeah, so Miralax is a complete constipation. It's a bulking agent, and that's absolutely fine if you take that daily. That's generally like my last sort of level on the on the constipation scale as far as taking it daily. It is the most potent, put it that way. So if you need to take it daily, then taking it daily is absolutely fine. So my general rule is start with kind of fiber supplements, increase water intake. If that doesn't work, go to stool softeners. If that doesn't work, then you look at like Miralax, either, I said, as needed or daily. If you find you have to take it daily, then you do. Generally, though, said your body will adjust to it over the course of time with medications. So hopefully you can kind of back that down. But if you need to take it, then that's fine. Some people take it without the medication, without taking GLP-1s. They have to take Miralax daily, so it's fine.
perfect. And so one of our patients, she's experiencing some side effects.
Mhm.
She's on week 10 and with 53 units, and she's noticed that she's been losing weight, but also she's noticed some fatigue, which I think is pretty general, and also the patient is losing hair.
Mhm.
So I guess what's your recommendation for this patient, and how should they go about, like, mitigating their side effects?
So hair loss is right now the most difficult and most distressing thing for patients with GLP-1s. It's not fully completely understood. Our hair follicles do have GLP receptors, so there is some activation somehow with GLP with hair. Um, we also see weight loss. We also see hair loss with things like gastric surgeries, so not involve GLP-1 medication. So there is some thought that maybe it is just the shock system of the body. Again, when your body goes into kind of starvation mode, it tries to hang on to all unessential. It tries to hang on to essential functions and kind of get rid of all unessential functions. And our hair is sort of an essential function to our body. So some of the thought is just the shock, the stress, the body kind of sheds hair. You see it with lots of other kind of stress reactions. Um, Generally, the hair does come back in 12 to 18 months once the sort of shock and the stress sort of resolve. Unfortunately, right now, there really is not a magic kind of treatment or magic pill to help it during this problem. It can be, fairly severe with medications. Generally, I found even decreasing the dose doesn't tend to help a ton. People still report that they're kind of shedding and losing with that. Best thing you can do is just scalp support. So making sure you're getting, vitamin supplementation. Make sure your vitamins are, especially if you're finding the appetite reduction. A lot of times we're losing vitamins, so making sure you're getting kind of multivitamin. Make sure you're taking like a biotin, usually marked under hair, skin, nail gummy. Those are great and fantastic. You can also do minoxidil. Topical minoxidil is great. Kind of helps increase stimulation to the hair follicles. Try to keep them going. Try to fight against that urge to lose the hair that your body is expressing. If you have a history, especially with women, if you have a history of iron deficiency, magnesium deficiencies, things like that, supplementation of those are important. Hasn't been much study showing that just adding iron on top of normal iron helps a lot. But if you're already low, if you're stopping cycles, you're having heavy cycles, you're prone to low iron. Adding iron supplementation, adding magnesium supplementation does help quite a bit. But again, it doesn't really show much benefit if you have normal or normal to high iron already. So again, unfortunately, that's one that no one's been able to sort of really nail down and figure out. Obviously, it's distressing for people. The best thing you can do is kind of do the supportive treatment as best you can, and it will kind of come back about 12 to 18 months once those follicles sort of regrow.
So, based on your experience, or at least from what it seems like, it's more of a shock factor and reduction in calorie intake, or for people who are not really like taking their protein on time, or like they're not really on par
Mhm.
with their regimen. It's more of a factor of just not having adequate amount of nutrition for your hair follicles, rather than necessarily like some sort of a magical interaction between the GLP-1 medications and your hair follicles that causes them to lose, to fall down, right?
Well, I said they're not 100% sure because there are some GLP-1 action within the scalp. It hasn't really been studied
Hmm.
very intensely. So that is a possibility that there is some interaction between GLP-1 specifically and hair loss. But as again, we also see the same sort of hair loss without GLP-1 therapy, just with weight loss. So it might be a combination of the both. It could be one more than the other. We really don't know.
Yeah, and according to the FDA's data, from what it seems like, when they did this study, they saw a relative hair loss of between the 3% of the population compared to 1% being on placebo.
Mhm.
So it's there. It's not as prevalent, but the data is very limited on it as
Mhm.
well. Okay, so let's move on to our one of our other questions that we have. We have Sandra, and we've already addressed that. Perfect. Okay, so let's go to the list of questions that I have.
So there was a question about premenopause or perimenopause or
Oh,
menopause.
really? Okay.
So again, perimenopause, menopause hormones, those are one of the things that again push on the scale. So unfortunately, with women, perimenopausal state, menopausal state pushes the wrong way on the scale. So again, these medications, they don't necessarily fix your other kind of perimenopausal, menopausal symptoms, but it does help again kind of correct that scale. So will it help you lose weight that you gained during perimenopause or after having like a hysterectomy, that kind of thing? Yes. By again, just kind of pushing the scale in the opposite direction.
And piggybacking off the topic of hair loss, we don't have our hairline yet coming up,
Mhm.
hopefully soon. But for those who are experiencing some sort of hair loss, if they are women, what percentage like minoxidil would you recommend to them? Or if they're men, what percentage of minoxidil would you recommend to the man? Or how should they go about like mitigating that sort of like
Yeah.
the
So
hair
generally, I mean,
loss one?
there's the it depends on whether you're doing like the liquid or the foam. They're all available over the counter as well. There's also compounding combinations, which are sometimes a little bit higher concentration that require prescription. But if you can't get a prescription, anything over the counter is all fine. They generally are, the same, the foam and the same concentrations across product. There's generic versions of those available too. There's also, minoxidil pills available. This can cause low blood pressure, especially if you're not keeping yourself hydrated a lot. But if you don't have a history of that, that's another option that might be a little bit more potent than the topicals too.
Mhm. Okay, perfect. Perfect. And I think, if I'm not mistaken, if the people who are buying like the over-the-counter minoxidils, I think it's the 2% for the women and the 5% for the men, and it's like I think this is
Mhm.
what the generic version is. Okay. One other question that I had for you is about the utility of GLP-1 medications on subjects other than weight loss. We're
Mhm.
seeing a lot of, I guess, data coming out about people who are on GLP-1 medications, and now they have a little bit less of an appetite for alcohol or like addiction. We've seen some regression in some cancer biomarkers in people who are on GLP-1s. Again, like the data is not strong. None of this stuff have been like thoroughly reviewed, but there's like overwhelming evidence about the utility of these medications on other aspects of medicine. So, I guess, what is your take on that, doctor? Have you seen anything interesting to for us to like learn about it and to be shared with our patients?
Yeah, I mean, I think this is all now that we have millions and millions of people on these medications, we're starting to see sort of those other effects kind of come through. Because again, they weren't studied initially. I said initially they were studied. They were looked at for diabetes, then happened to find that they cause weight loss, and then kind of went down this path. And now that many people are on them and also have all these other diseases, we're finding some small, some significant improvements and changes in all these other issues. So sleep apnea is an odd one even beside the weight loss. For some reason, some of the medications assist with sleep apnea. We've seen improvement in heart disease. We've seen improvement in cognitive functions, Alzheimer's, all these sort of risks that really have nothing to do with weight loss necessarily. Polycystic ovarian syndrome is another one. General sort of metabolic syndrome, fatty liver, things like that, like things that necessarily weight loss alone doesn't account for, that we're seeing a lot of changes with. I think a lot of people think of a medication, they think a drug, they think of it as like a lock and a key, right? The medication's a key, it opens one lock, and that's it. It fixes
Hmm.
this one thing, and that's what it fixes. But these sort of medications are almost more like a hormone. It kind of has a cascade. If you think of those like domino games where you line all the dominoes up and they split up into like 10 different rows and 10 more different rows, when you tip that first domino, it reaches out into all sorts of different other areas within our body. We talked about hair loss one, but also the beneficial ones that we really may not even know, that these medications can improve all of these things. And we're finding, month to month new avenues that, hey, maybe this actually is helping with Alzheimer's, heart disease, metabolic syndrome, things like that.
Hmm. Hmm. Yeah, and there's just a lot of new studies that are coming out. Another study on Johns Hopkins published that it helped with end stage kidney disease.
Hmm.
It plunged it by 19%. There was another study that came out about the cardiovascular health, reducing the cardiovascular disease by
Hmm.
14%. A lot of that has to do with obesity, but some of the other things, as you mentioned, like obviously it's like a cascade of events that are
Hmm.
not completely understood yet. And it's been helping with addiction apparently too,
Hmm.
because somehow it curbs your need for dopamine in general.
Right.
So these are all interesting things that are coming out. So I'm really like, I guess we would know more, and then on our
Right.
next section we can definitely talk about it.
And
Um,
that actually ties into the question before with the fatigue. That is one of the ways that some people have postulated that it leads to the fatigue, is it is sort of, reducing sort of the dopamine hit. So while it does help with sort of the overuse of dopamine, things like addiction process, things like that, that it may actually be causing some fatigue and decreasing some energy levels that we get from those sorts of things. So again, sometimes the plus, sometimes the minus.
100%. And bodies are different from one another.
Mhm.
The same way that somebody drinks coffee and like they just get jittery, there's another person who gets more focused. And
Yep.
I've actually talked to a patient who has a surge of energy every time that they take these medications.
Mhm.
I don't know how it works, but it does work. It varies from patient to
Mhm.
patient. So yeah, just keep that in mind for our viewers. Um, Last question. What new medications, products, and services are coming into NexLife? And this is something that I can probably talk about a little bit, and Dr.
Yeah.
Kennah can 100% talk about it. What are the things that you think would be helpful for our patients for us to bring, and what are the things that we're bringing in and we're excited about?
Yeah. Well, why don't you guys say what we've got lined
Yes.
up, and I can tell you
Yes,
why.
so 100%. So yes, we have we are focusing right now on our, some of the products that we're bringing in. And obviously, we talked about the hair products that we're trying to like bring in. One of the things that we've been discussing with at our CEO at our board meetings was potentially bringing in like the 3-in-1 pills, because I personally think that the people who are like taking the dutasteride over the finasteride are seeing far more results than just the finasteride alone. And then added factors to it would be, I guess, minoxidil and also biotin. And
Mhm.
minoxidil, the peel version of it, have shown to be a great added component to the already existing dutasteride, which I think is far more effective than, I guess, finasteride. And for those who don't know, dutasteride is a dual blocker. Usually, I guess the dosage, and please correct me if I'm wrong, is like half the dosage, but it affects both enzymes, both
Mhm.
5-alpha reductase 1 and 2, and massively reducing the DHT. And DHT is the
Mhm.
follicle, the thing that binds to the hair follicles and makes it
Mhm.
fall off. And there's overwhelming amount of evidence over the efficacy of dutasteride versus finasteride, but these are one of the things that I think we're working on bringing it on. And also we are working on other peptides,
Mhm.
like some of the peptides that I think is very interesting, and hopefully potentially bring it on soon, would be sermolene and ipamorelin and things of that nature.
Mhm.
So I guess, what do you generally think about this whole peptide world, doctor? And I guess we can start off by talking about the hairline products, and then maybe later on about some of the other controversial slash
Mhm.
interesting things like the peptides that are hitting the market right now, and some of the other companies are bringing it too.
Right. So the peptide market kind of brings us back to the FDA approval
Mhm.
market, which is, the peptides that you hear discussed. There's no money in them for one company, right? They're not owned by one company. So if, for example, a study comes out that shows that a certain peptide has a good effect for whatever problem, there's not one company that's going to benefit from that. Right. So as opposed to, like, when these companies, put Zepbound on the market, there's a ton of money for them alone to make with Zepbound. But there's really not a lot of money, for example, with Sermorelin or BPC or NAD plus, because these just are either generic or they're compounds that are already available they're already have been found forever ago, and are not owned by a certain company. So no one's going to run that study, because no one's going to make money off of that study. No one company's going to make money off that study.
Mhm.
So if you look at something like Sermorelin, Sermorelin actually is FDA approved for a very specific function years ago. So it went through the safety trials, was found to be safe. It was found to work for a very small niche audience. It turned out that audience couldn't maintain, wasn't enough people there to maintain profitability. So that company just abandoned it. And now it's being used sort of for muscle retention, particularly in older folks or with weight loss, things like that. But again, no one's actually going to run that study to show any benefit, because it's available to everyone. So, if one company invested millions of dollars, then everyone's going to benefit. It doesn't help them. Uh, so again, the biggest concern with these peptides is making sure you're getting it from a reliable source, because there are lots of people that are making it in their garage or whatever, and they're selling them as research grade. And they say research grade, that could be anything. So the main key is making sure you're getting it from a reputable source, getting it from a reputable pharmacy, that it's still sterile. It's still things you're injecting, so you still want it to be sterile and prescription grade. But again, these will never be FDA approved fully, because no one's going to run that study.
And not just a reputable pharmacy with a source, but the source has to be working with reputable pharmacies too. This is
Right.
one of the things that we're seeing. Some of the companies that have their own actually pharmacies, and those pharmacies, they don't nearly adhere to the FDA regulations. Some videos came out of a pharmacy that looked like basically like a Costco store, and with
Mhm.
like, and they were just like, people were just running all over the place, and there was no septic or aseptic. Like, you couldn't discern which one is septic, which one's
Mhm.
aseptic. So they're just like throwing everything on top of each other and sending it out to the patient. So I guess our recommendation, and this is something that we're seeing a lot, and that's very, very unfortunate. It's usually happening with those companies that are offering their services for, I guess, a fraction of the price, like $20 injections. And
Right.
if anybody types it in right now, they could see some ads. I think they're going to see some ads right now after watching this video,
Yeah.
anyways. But yeah, $20 injections, and then when you dig into it, if you actually get the medication, you never know where that medication is coming from,
Mhm.
even if it's in a compounded in a pharmacy in America. So what we try to do is that we try to like vet these pharmacies. We work with pharmacies that are extremely reputable, and they're like servicing a lot of the states, and they've had a track record of
Mhm.
consistency with very, very, very low risks and of contamination and
Mhm.
things of that nature. So this is something for all of our viewers to be mindful of. If you are getting a medication that is going to be affecting your metabolism, it's a peptide. It's generally more safe than steroids, but there's a lot of it's a cascade of events, as Dr.
Mhm.
Kennah perfectly alluded to. So just make sure that you're getting it from not only a reputable company, but a company that is getting it from a good source. So I guess that's just my recommendation on top of that. But yeah, this is where the fun part is, Dr. Kenna. I really appreciate your time. I know it's your Sunday and you're taking the time out of your day, so we really appreciate it. We always love talking to you. But this is where the fun part is, and I want you to pick two people on your end for us to give him a $50 gift. So the way it works with us, guys, and our viewers, when your name is called out, you're gonna have to send us a DM, and then we will be able to verify it because we're going to save the video and we're going to hopefully use it for our YouTube channel, and so people can go back and see it and maybe get some clips out of it. So yeah, so we're going to be calling out your
All right.
name. When we call out your name, you're going to have to send us a DM. Okay. So Dr. Kenna, please go ahead and pick two lucky patients or viewers.
Is the hardest part. So we got two right in front of us there. So Girly Girl was asking a lot of questions, and then Dapper American Chap did respond. Actually helped us out. So we'll
Mhm.
go with those two.
Okay. So guys, please go ahead and send us an email. Sorry, send us a DM, and then we're going to be able to see and verify your account, and we're going to go ahead and send those $50 gifts to you guys. Any last minute questions, guys, before we let you go? I guess not.
No.
Okay. Well, Dr. Kenna, thank you so much for your time. Really appreciate it. And hopefully we'll do this in the next couple of weeks, and it's going to be fun.
So one question. So I had a BUD date question.
Oh,
So
sorry.
technically, no. Technically, the vial date, the vials aren't good after the best use date. Um, from a legal standpoint, again, it's kind of like milk in the fridge. I can't tell you to risk it, but if you, that's on you. But legally, no. We have to say no. You can't use it past the best use date.
Perfect. Thank you so much, everyone. Thank you so much, Dr. Kenna, and
Yeah.
happy Sunday.
Awesome. All right. Thank you,
All right.
everybody.
Goodbye.
Bye.